Cerebral palsy. Cerebral palsy has been defined as a disorder of posture and movement from static brain injury perinatally or postnatally, which limits activity. In addition to motor disorders, the condition often involves disturbances of sensation, perception, communication, cognition, and behaviors. Secondary musculoskeletal problems and epilepsy often occurs. The etiology, clinical features, and course vary, and they're characterized by abnormal muscle tone and coordination as the primary disturbances. So although we may see all of these manifestations, the primary clinical symptom that we'll see is abnormal muscle tone and decreased coordination. So without even going any further, you can tell that the patient with cerebral palsy, one of our biggest concerns is going to be what? Respiration, safety, falls. Okay, that's what you said. I didn't hear you back there. Yes. Safety is a big issue. Absolutely. Etiology. It is now believed that cerebral palsy results more often from existing prenatal brain abnormalities. However, the exact cause of these abnormalities remains elusive. In general, infants exposed to maternal and perinatal infections are at increased risk for the development of cerebral palsy. Additional factors that can contribute to the development of cerebral palsy postnatally include bacterial meningitis, multiple births, viral encephalitis, motor vehicle accidents, and child abuse such as shaken baby syndrome, causing traumatic brain injury. Clinical manifestations. First one we're going to talk about is delayed gross motor development. Delayed gross motor development is a universal manifestation of cerebral palsy. The child shows a delay in all motor accomplishments. So they're not reaching any of their milestones at the time they're supposed to be reaching those milestones. Delayed development of the ability to balance may also slow the progression of the milestones. Look at box 49.2. Other manifestations that you guys need to know about. So we have the delayed gross motor development, abnormal motor performance, alterations of muscle tone, abnormal postures, reflex abnormalities, and associated disabilities. Make sure you guys take a look at that. Diagnostic evaluation. The neurologic examination and history are the primary modalities for the diagnosis. Neuroimaging of the child with suspected brain abnormality and cerebral palsy is now recommended for diagnostic assessment along with MRI. The nurse should monitor infants with known etiologic risk factors and evaluate them closely in the first 2 years of life. More often, the diagnosis cannot be confirmed until the age of 1 to 2 years. Why? Because motor tone abnormalities can be indicative of another neuromuscular condition. Therapeutic management. The disorder is permanent. It's permanent, and therapy is chiefly symptomatic and preventative. There's no cure. So we want to treat the symptoms as they come along and prevent things such as injury from happening. The broad aims of therapy are to 1, establish locomotion, communication, and self-help skills. 2, gain optimum appearance and integration of motor functions. 3, correct associated defects as early and effectively as possible. 4, provide educational opportunities adapted to the individual child's needs and capabilities. And 5, promote socialization experiences with other affected and unaffected children. As far as mobilizing devices, many children with cerebral palsy wear ankle foot or orthoses. These are braces. Wheel go-karts provide good sitting balance and serve as early wheelchair experience for young children. Surgery, orthopedic surgery may be required. As far as medications, intense pain may occur with muscle spasms in this patient. Pain management is an important aspect of the care of the child with cerebral palsy. Botulinum toxin A is also used to reduce spasticity in targeted muscles of the upper and lower extremities. You guys know what this is? Botox, that's right. AEDs, anti-epileptic drugs, are used for those patients from the seizures. Associated problems. Dental care is especially important for children with cerebral palsy and often is overlooked. Regular visits to the dentist and dental prophylaxis, including brushing, fluoride, and flossing after several teeth are present, should begin as soon as the teeth erupt. This is especially important for the child given Fenton. That's what Dilantin. Remember that gingival hyperplasia you guys learned about last semester? So especially that patient that's on Dilantin who often develop gum hyperplasia. Physical therapy. Physical therapy is one of the most commonly used treatment modalities in children with cerebral palsy. Speech therapy. Excuse me. Speech training under the supervision of a speech language pathologist begins early before the child learns poor habits of communication. All right, let's move on to the effects of neural tube closure. And on the side here, I wrote folic acid. That's what you need to be thinking about. You'll understand why in a second. Abnormalities that derive from the embryonic neural tube defects constitute the largest group of congenital anomalies with multifactorial inheritance. Failure of the neural tube closure produces defects of varying degrees. Box 49.4 neural tube defects. Make sure you guys know these terms. You guys know the encephalocele, that's herniation of brain and meninges. Meningocele, hernial protrusion of a sac-like cyst of meninges. And myelomeningocele, that's hernial protrusion of a sac-like cyst containing meninges, spinal fluid, and a portion of the spinal cord with its nerves. Make sure you guys know the difference. Most authorities believe that the primary defect in neural tube defects is a failure of the neural tube closure during the embryo's early development. However, evidence also indicates a multifactorial origin, including drugs, radiation, maternal malnutrition, chemicals, and possibly mutation in folate pathways. Additional factors predisposing the infant to neural tube defects include, make sure you guys know this list, maternal obesity, previous neural tube defect pregnancy, Hispanic ancestry, low folic acid intake, ding, 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 put a star next to that one, gestational diabetes, use of a hot tub or sauna, low maternal vitamin B12, and the use of anti-epileptic drugs such as valproic acid during pregnancy. The American Academy of Pediatrics Committee on Genetics recommends daily intake of folic acid for all women of childbearing age. Did it say daily use of folic acid for women who are pregnant? Of childbearing age. Because you may be pregnant, not know you're pregnant, right? Okay. The recommended 0.4 milligrams daily dose is supplied safely in many multivitamin preparations. Sexually active females should be counseled on the risk of inadequate folate intake. That is your key when it comes to the neurotube defect for testing purposes. You remember how in box 49.4, I told you need to know the differences of those neurotube defects? Well, in the figure, they give you a visual illustration. So you have your normal meningocele, and I circle the area so you can see the difference. Meningocele versus your spina bifida and your myelomeningocele. Make sure though, these box guides, you guys can recognize the differences. You see a difference how it's protruding? This one's normal. Nothing's protruding outwards, right? But over here versus here versus here. Oh, there we go. All right. Myelomeningocele. Myelomeningocele develops during the first 28 days of pregnancy when the neural tube fails to close and fuse at some point along its length. Diagnostic evaluation. The diagnosis, what's SB? Spina bifida. The diagnosis of spina bifida is made on the basis of the clinical manifestations from box 49.5, that's this box up here, and examination of the meningocele sac. Just looking at that sac, they'll be able to tell what type of neural defect the patient has. Flaccid paralysis of the lower extremities is a common finding with absent deep tendon reflexes. So paralysis of the lower extremities and absent deep tendon reflexes is very common. Prenatal detection. Ultrasound, okay, ultrasound of the uterus and elevated maternal concentrations of alpha-fetoprotein, a fetal-specific gamma-1 globulin in amniotic fluid may indicate encephaly or myelomeningocele. This is important. Make sure you guys know this. The optimum time for performing these diagnostic tests is between 16 and 18 weeks of gestation before AFP concentrations normally diminish and in sufficient time to permit a therapeutic abortion. You guys learned this already.
Say protein and the spontaneous rupture membranes.
Is that the same protein then?
Like when you water breaks in the spontaneous rupture membranes, I think it's the same protein. Yeah, you test it to make sure that it is the amniotic fluid.
Oh, okay. The FERN test that they do.
No. It's the amniotic fluid.
Yeah.
No, he's asking when they do the FERN test to make sure that it's the amniotic fluid and not something else. Is it that this protein that they're looking for in the amniotic fluid? That's what he's asking. That is what you're asking, right? Sorry. Yeah, that's what he was asking. Excuse me. But you guys are expected to know the time frame between 16 and 18 weeks. Therapeutic management. Management of the child who has myelomeningocele requires a multidisciplinary team approach. Whenever they tell you multidisciplinary team approach, that means everybody's going to be on the case. You're going to have dietitians, you're going to have physical therapy, you're going to have OT, you're going to have everybody's going to be on this case. And they give you the list of why. All right, next page. They may have surgery, neurosurgical, and plastic surgical procedures. Initial care. Surgical closure within the first 24 hours is recommended if the sac is leaking. Early closure, preferably in the first 12 to 18 hours, not only prevents local infection and trauma to the exposed tissues, but it also avoids stretching of other nerve roots, thus preventing further motor impairment. Prevention. The Centers for Disease Control and Prevention continues to affirm that 50 to 70% of neural tooth defects can be prevented by daily consumption of 0.4 milligrams of folic acid by women of childbearing age. To ensure adequate daily guys, to ensure adequate daily intake of the recommended amount of folic acid, women must take folic acid supplement, eat a fortified breakfast cereal containing 100% of the recommended dietary allowance of folic acid, or increase their consumption of fortified foods. They're giving you examples: cereal, bread, rice, grits, pasta, and foods naturally rich in folate, such as green leafy veggies, citrus fruits. Drugs that affect folic acid metabolism and increase the risk for myelomeningocele should be avoided before pregnancy. If plans are to become pregnant in the near future and during pregnancy, these include trimethoprim and AED, that's your anti-epileptic drugs such as carbamazepine, dilantin, phenobarbital, valproic acid, those types of medications, because we've seen an association with those medications and neural tooth defects. Care of the myelomeningocele sac. The infant is usually placed in an incubator or radiant warmer so that temperature can be maintained without clothing or covers that might irritate the CNS lesion. Before surgical closure, the myelomeningocele is kept from drying because it has to remain moist, it can't dry out. It's kept from drying by the application of a sterile, moist, non-adherent dressing. And Clex expects you to know that. The moistening solution is usually sterile normal saline. Dressings are changed frequently every 2 to 4 hours, and the sac is closely inspected for leaks, because remember, if there's a leak, we got to do surgery right away. It's inspected closely for leaks, abrasion, irritation, and signs of infection. Positioning, and Clex expects you to know this as well. Before surgery, the infant remains in what position? Prone. And it makes sense. Why would you have them supine? Right? So they're going to be prone. They're going to be in a prone position to minimize tension on the sac and minimize the risk of trauma. The prone position allows for optimal positioning of the legs, especially in cases associated with hip dysplasia. Prone. Again, the prone position is maintained after operative closure, although many neurosurgeons allow a sideline or partial sideline position unless it aggravates a coexisting hip dysplasia, blah, blah, blah. Guess what? For testing purposes, you ever see a question about neural tooth defects, you better choose prone position. Okay? All right. Moving on. Let's talk about latex allergy. God bless you. Children with spina bifida are at high risk for developing a latex allergy because of repeated exposure to latex products during surgery and procedures. Therefore, such children should not be exposed to latex products from birth onward to minimize the occurrence of latex hypersensitivity. Allergic reactions range from urticaria, that's when they break out in hives, wheezing, watery eyes, and rashes to anaphylactic shock. There also can be cross reactions to a number of foods. If I had a penny for how many times this has been seen, not only on NCLEX, but ATI has the idea of rich woman, okay? You better know these foods: banana, avocado, especially kiwi, and chestnut.
Increasing that sensitivity to latex.
These types of foods, there's some, I don't remember the name of the protein. There's some type of protein in there that is also in latex products. So if the person's allergic to latex, they shouldn't be exposed to any of these foods. I don't remember the name of the protein, but it's some type of protein. Identifying latex allergy, ask questions, assess. Questions like, has your child had an allergic reaction during surgery? What would you do if an allergic reaction occurred? Has the child had any allergy testing, etc.? Guillain-Barré syndrome. Guillain-Barré syndrome, also known as, you see this where I'm not going to try to pronounce it. You see it? This is an uncommon acute demyelinating polyneuropathy with progressive, usually ascending flaccid paralysis. Let's stop right there because it's saying a lot to us. It's progressive. That means as time goes on, it only gets worse, right? Usually ascending. Well, you know, most disorders, they're descending. This one starts from the bottom and it creeps its way up, okay? Ascending flaccid paralysis. The hallmark, ding, 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 ding. The hallmark of Guillain-Barré syndrome is acute peripheral motor weakness. The paralysis usually occurs approximately 10 days after some type of viral infection. Guillain-Barré syndrome has also been reported after the administration of certain vaccines. Diagnostic evaluation. Diagnosis is based on the paralytic manifestations, cerebrospinal fluid analysis, and EMG. CSF, cerebrospinal fluid analysis, reveals an elevated protein concentration, fewer than 10 WBCs, and normal glucose level. Therapeutic management, supportive. Prognosis. Recovery usually begins within 2 to 3 weeks, and most patients regain full muscle strength. I cannot remember exactly how the question goes, but there's a famous question. It's a patient that's been diagnosed with this. She had weakness. She went in the hospital. You walk into the room and she's in tears crying, and you ask her what's wrong, and she says that, you know, she's so upset because she doesn't have enough money to get a caregiver for someone to take care of her for the rest of her life. What is your response going to be? And, you know, the choice for something like, you know, I'm so sorry you have to deal with this, blah, blah, blah. But the correct answer is that this is something, basically, this is something that comes and it's going to go. And the thing is, with Guillain-Barré, remember how it starts by ascending, right? When it starts to go away, it goes away by descending. So the last area of the body that was affected, that's going to be the first one to recover, going down, okay? All right, tetanus. Tetanus or lockjaw is an acute, preventable, and sometimes fatal disease caused by an exotoxin produced by the anaerobic spore-forming gram-positive bacillus Clostridium tetani. It's characterized by painful muscular rigidity, primarily involving the masseter and neck muscles. Tetanus spores are found in, and Clex expects you to know this list, soil, dust, and intestinal tracts of humans and animals, especially herbivorous animals. They enter the body by way of wounds, particularly a puncture wound, burn, or crushed area. The disease has the greatest incidence during the months in which persons are more involved in outdoor activities. Prevention. Primary prevention is key and occurs through immunization and boosters and good wound care. Protective levels of antibody are maintained for at least 10 years. Children with more serious wounds, contaminated, puncture, crush, burn wounds are given a tetanus toxoid booster prophylactically as soon as possible after the injury. So even though that tetanus shot is good for 10 years, let's say they step on a nail, right? Then they're going, even though it hasn't been 10 years, they'll still get that booster. The unprotected or inadequately immunized child who sustains a tetanus-prone wound, including wounds contaminated with dirt, they're giving this to you again, guys. Dirt, feces, soil, saliva, puncture wounds, avulsion, wounds resulting from missiles, crushing burns, and frostbite should receive tetanus immunoglobulin. Concurrent administration of both TIG, that's the tetanus immunoglobulin, and tetanus toxoid at separate sites is recommended both to provide protection and to initiate active immune process. And down here I wrote, always give IM in separate syringes at separate sites, never give IV. So when you give them at the same time, guys, you're not going to give them the same syringe. You're going to give them in different syringes in different sites, and it's going to be IM, never IV. Can I keep going? Okay. Therapeutic management. Antibiotic treatment with penicillin G or erythromycin or tetracycline if they're allergic to penicillin is important in the management of tetanus as an adjunct against Clostridia. And this one right here is a viable alternative. TIG, the tetanus immunoglobulin. TIG therapy to neutralize toxins is the most specific therapy for tetanus. In countries where TIG is not available, equine tetanus antitoxin should be administered. Antibiotics are administered to control proliferation of the vegetative forms of the organisms at the site of infection. Botulism. Botulism is a serious food poisoning that results from ingestion of the preformed toxin produced by the anaerobic bacillus Clostridium botulinum. The disease has a wide variation in severity, from constipation to progressive sequential loss of neurologic function and respiratory failure. Foodborne botulism. The most common source of the toxin is, look at this, improperly sterilized home canned foods. Diagnostic and therapeutic management. Treatment consists of immediate administration of botulism immune globulin intravenously. This we're given IV. You give it without delay for laboratory diagnosis. So you don't even wait for the confirmation. Nursing alert. It's still recommended that hot honey not be given to infants younger than 12 months because the spores have been found in honey. Most infants recover when the disorder is recognized and the BIGIV therapy is implemented. Parents should be aware that during recovery, infants fatigue easily when muscular action is sustained. This has important implications for the timing resumption of feedings because of the risk of aspiration. They should also be advised that normal bowel activity may not return for several weeks. Therefore, a stool softener can be beneficial. I know you guys love when I turn those pages, right? Duchenne. Duchenne muscular dystrophy. And on the side here, guys, I wrote severe muscle weakness. When you see Duchenne, I want you to think of severe muscle weakness. DMD is the most severe and most common, what's this MD stand for? Oh, muscular dystrophy in childhood. It's inherited as an X-linked recessive trait and the single gene defect located on the short arm of the X chromosome. It's important that you guys know it's X-linked, okay? As in all X-linked disorders, males are affected almost exclusively. You guys finally get something that belongs to you.
That the father would use it too. But the father didn't.
I have no idea. Look it up, you tell me. Is that it?
No, the X comes from the mom.
No, I know the X, that's true. X is women, wife, male. The female character may have an elevated serum creatinine kinase, but muscle weakness is usually not a problem. Something's finally going our way. Dystrophin is absent from the muscle of children with DMD and is reduced or abnormal in children with Becker MD. Signs and symptoms: early onset, usually between 3 to 5 years of age, progressive muscular weakness, wasting, contractures, relentless progression until death from respiratory or cardiac failure. And you need those muscles to help you breathe, right? And your heart's a big old muscle. Clinical manifestations. Most children with DMD reach the appropriate developmental milestone early in life, although they may have mild, subtle delays. Evidence of muscle weakness usually appears during the 3rd to 7th year. Muscles, especially in the calves, thighs, and upper arms, become enlarged from fatty infiltration and feel unusually firm or woody on palpation. The term pseudohypertrophy is derived from the muscular enlargement. They'll have contractures, deformities. Ambulation usually becomes impossible by the time they're 12 years old. Ultimately, the disease process involves the diaphragm and auxiliary muscles of respiration, and cardiomegaly is common. Mild to moderate mental impairment is commonly associated with MD. Complications. The major complication of MD includes contractures, scoliosis, disuse atrophy, infections, obesity, and respiratory and cardiopulmonary problems. Diagnostic tests. Over here, guys, I just highlighted the manifestations that we already talked about, so you guys can read that more in detail: pulmonary infections, obesity, cardiac manifestations. Diagnostic evaluation. DMD is suspected on the basis of clinical manifestations and is confirmed by molecular genetic detection of deficient dystrophin by DNA analysis. They can also do a PCR, serum enzyme measurement, muscle biopsy, and EMG may also be used to establish a diagnosis. Therapeutic management. Currently, no curative treatment exists for childhood MD. They can get corticosteroids. Maintenance of function often includes stretching exercises, strengthened muscle training, breathing exercises, and use of incentive spirometry to increase and maintain vital lung capacity, airway clearance, range of motion exercises, surgery to release contracture deformities, bracing, and performance of ADLs. Referral to palliative care may help the family evaluate the benefits and burdens of various treatments. This is something you have to be very sensitive about when you bring it up to the family. Patient can get manual cough assisting techniques. Survival in individuals with DMD may be prolonged several years with the use of non-invasive ventilation and airway clearance devices, such as cough assist as alternatives to tracheotomy and airway suctioning. Nursing management. It's tempting for parents to overprotect their affected children. Children derive pleasure and build self-esteem from performing actions that visibly please their parents. Therefore, parents must be helped to develop a balance between limiting the child's activity because of muscular weakness and allowing that child to accomplish things on their own. Many parents erroneously believe that by exerting sufficient effort, the child can overcome the weakness and prevent progression of the disease process. They should also be advised to notify the nurse or other designated person when the child becomes even temporarily bedridden, so that the exercise program can be modified and continued during this time. And I wrote this on the bottom. It's important for you guys to know. They tend to live up to their early 20s. And that's with everything, all of these therapies that we talked about, they can live up to their early 20s.